Welcome, welcome everybody. You are entering the world of Silver Hill Grand Rounds, and so excited to see you. We'll get started here in just a moment. All right. Thank you, everybody, for tuning in, for joining us today. I'm Dr. Jeff Katzman. I'm the Director of Education here at Silver Hill Hospital. And again, we're just delighted to have you join us today and are really privileged to welcome old colleague of mine, Dr. Steve Marder, who will be presenting on the topic of new pharmacotherapy for psychosis. And I'll have the pleasure of introducing him in just a moment. First, a little bit of housekeeping. Our next grand rounds takes place on May 7th with Dr. Joyce Shea, who will talk to us on the topic of integrated behavioral health care models and outcomes of care. And to see all of our Silver Hill Share events, our series that we're putting on, our grand rounds, just take a look at our calendar at silverhillhospital.org/calendar. So back to today's lecture, your questions remain, as always, an important part of our grand rounds, and I'll moderate a Q&A discussion with Dr. Marder at the end of his lecture. This is a great opportunity to put forward questions and comments to Dr. Marder, which you can submit anytime during the lecture by using the Q&A link. If you would like CME or CEU credits today, please complete the evaluation survey that will automatically show in your browser when we end the webinar. A link to the survey will also be emailed to everybody who's participated today tomorrow. Note that this email will be a Zoom email coming from Silver Hill Hospital events. The email will also contain a link to the recording and slide presentation. Please keep your eye out for that. And so that all participants have enough time to complete the survey, it will remain open until the end of the day on Friday. Certificates will then be emailed within a week. And any questions, please contact us at shhevents@silverhillhospital.org. Finally, disclosures. No planners of this activity have indicated a relevant financial relationship with an ACCME defined commercial interest, and Dr. Marder will show a slide with his disclosures. And now it is really a great pleasure for me and honor to introduce our guest speaker today, Dr. Stephen Marder, who is a professor of psychiatry and the director of the section on psychosis at the UCLA Semel Institute for Neuroscience and Human Behavior. He's also the director of the Vision 22 Mental Illness Research Education Clinic Center, that stands for MyREC, for the Department of Veteran Affairs. Dr. Marder's research is focused on improving the lives of individuals with psychotic disorders, particularly schizophrenia. His research, supported by the VA, the Brain and Behavior Research Foundation, and the National Institute of Mental Health, has focused on the development of pharmacologic, psychosocial, and rehabilitation approaches for improving functioning and quality of life. Dr. Marder has received the Exemplary Psychiatrist Award from the National Alliance for Mentally Ill, the Stanley Dean Research Award of the American College of Psychiatry, the Alexander Gralnick Award from the American Psychiatric Association, the Kempf Award from the American Psychiatric Association, the American Psychiatric Association Award for Research, the Wayne Fenton Award for Outstanding Clinical Care from the Schizophrenia Bulletin, and the Lieber Prize for Schizophrenia Research. Dr. Marder has been at all this for a little while. He was an esteemed faculty member actually at UCLA when I was a resident there, and actually was my first boss at the West LA VA, where he was the chief of psychiatry at the time, and really honestly created an atmosphere in which it was a joy to come to work each day, and it was an honor to start my career working for Steve. So Dr. Marder, thank you so much for answering my email and agreeing to talk to us and share your wealth of knowledge on the new psychopharmacology for psychosis. And I'm going to disappear here for a moment, and we'll be back at the end for a Q&A with you.
Okay. Okay. Um, so hopefully my slides are showing. Uh, and it's a pleasure to be here. And it's wonderful to have an introduction by Jeff. Um, so I'll start with my disclosures. And my disclosures are really very relevant to this talk because I'll be talking about a number of drugs that are in development. And for many of them, I've been involved as a consultant. And this includes, a synovian drug, a neuron drug, Karuna, which developed uh, xanomeline trospium, which I'll talk about at length. Um, so again, I think these are very relevant. Um, these are my educational objectives. I'm going to be talking about new drugs. I think there's great interest in muscarinic antipsychotics, and I'll talk about how those drugs work and talk a bit about what we know clinically about these drugs. I'm going to talk about the new compounds and their side effects and their effectiveness. And for the third, I was originally, when I planned this talk several months ago, describe the mechanism of action of drugs for treating cognitive impairment in schizophrenia. However, I'm not going to do that. That there was a drug which was in development and by Beringer for treating cognitive impairment in schizophrenia. Uh, when the study read out in January, it read out as negative. So I'm not going to discuss that at all. Uh, what I will talk about are new antipsychotics with different mechanisms. We'll talk about muscarinic compounds, which xanomeline trospium is the one that's available now. TAR1s, which I think will be available relatively soon. A couple of other drugs, roluperidone, brilaroxazine, and N-methylamine. And then we're going to talk about a drug that's in development for treatment-resistant schizophrenia, which has always been an interest of mine. Um, this sort of gives the historical perspective on antipsychotics, and it gives me an opportunity to talk a little bit about my career. Uh, I started research here at well, initially at the NIH in Bethesda, and then at UCLA in the greater Los Angeles VA as an inpatient psychiatrist. And my research interest was in sort of managing the burden of antipsychotics, that we believed that many patients were sort of suffering from side effects, and that these side effects were really impairing their quality of life. I talked, our research focused on strategies for reducing that burden, for identifying side effects. Uh, Things changed when clozapine first became available. I think that was probably one of the most exciting events in my career because suddenly there was a drug that was effective for treatment-resistant schizophrenia. Uh, and then the introduction of the second generation antipsychotics, which was helpful. We were, during the 1990s, on the ward that I ran, we did early trials on risperidone, olanzapine, aripiprazole, quetiapine, and began to see both their advantages and their problems. And actually, since then, there have been a number of introductions, but all of these drugs have functioned by the same mechanism. They've all, including clozapine, they've all blocked dopamine receptors, and they've come with the disadvantages of that. mechanism, which is people develop neurological side effects. Many of them cause weight gain. They elevate prolactin. And, you know, psychiatrists don't talk about it, but blocking dopamine receptors takes a little bit away from the quality of life of many of our patients. We have to do that, and many of our patients are doing well. But the introduction of the first non-dopamine antipsychotics to me is a really a landmark, and one that makes me excited, and hopefully you'll be excited too as we begin to see these drugs actually come to market and we're able to treat patients. Now, there are a couple of recently introduced antipsychotics that I just want to mention because it's consistent with the title. Lumateperone is a drug that's a 5-HT2 and D2 antagonist, and it has greater separation between its serotonergic and dopaminergic effects. It does have relatively low EPS. It causes minimal weight gain. It doesn't increase prolactin, but it still, works by the same overall mechanism. And I suspect that many of you are prescribing lumateperone. I don't think it earned a special place as a drug for treatment-resistant patients and for other things. Olanzapine samidorphan is a formulation of olanzapine, which attenuates olanzapine-induced weight gain. I think some of us have found it useful. It's important to mention that it's not a drug for weight loss. It's really a drug that is associated with weight gain, but weight gain that's less severe than with olanzapine. So what I'd like to spend most of this talk focusing on is how new drugs are being developed that don't block dopamine receptors and how they work. Our current understanding of psychosis has kind of evolved during the past decade. I think most of us accept that antipsychotics work by blocking dopamine receptors, at least all of the current antipsychotics up until xanomeline trospium. But now I believe that most people think that the problem isn't at the dopamine neuron, but it's higher up in centers that actually stimulate dopamine. So it's the path for treating psychosis runs through a dopamine for these drugs, but that's not necessarily the cause of the illness. What the new drugs seem to do is they have alternative approaches for normalizing hyperactive dopamine transmission without actually blocking dopamine receptors. For xanomeline trospium, which I'll call XT, or the brand name is Carbenfy. It does it by activating muscarinic receptors, both M4 and M1, and I'll talk about that in greater detail. There are other drugs that reduce the firing in ventral tegmental area dopamine neurons using drugs that affect trace amine receptors, or TAR1s. These are TAR1 agonists. Other drugs are focused on normalizing the activity of hyperactive hippocampal glutamate neurons, which actually attenuate dopaminergic tone. And there are other drugs that seem to moderate hyperactive glutamate by antagonizing sigma receptors. So again, these are mechanisms. This is from a slide figure by Oliver Howes from a recent article in Biological Psychiatry. which shows the same thing. So if you look at that kind of purplish dopaminergic neuron, this is not a drug. The drugs that we're looking at aren't drugs that block dopamine receptors. These are drugs that decrease the activity, attenuate hyperactive dopaminergic activity through other pathways. That could be they could be muscarinic, they could be using trace amines, or focusing on glutamate. So, to the first group of drugs, and I'll talk about these in much greater detail because xanomeline trospium is actually available, and I suspect that many of you have already prescribed it and you're learning about it. And I'll tell you a bit about what I've learned. So the idea that you could treat psychosis with a cholinergic drug has been around since the 1950s, when early studies were done. In the early 2000s, it was noted that betel nuts, which have high concentrations of arecaline, can actually decrease the severity of positive and negative symptoms in schizophrenia. Then in 1997, Eli Lilly was studying a drug, xanomeline, for improving cognition in Alzheimer's disease. What they noticed was that xanomeline in Alzheimer's patients who were psychotic seemed to have antipsychotic effects, which was surprising. And xanomeline was dropped by Eli Lilly because the xanomeline side effects were too severe. But this sort of compelling property of xanomeline was carried forward in other studies. Now, how can a muscarinic drug, and again, you remember that there are two types of muscarinic receptors, two types of acids, acetylcholine receptors, both muscarinic and nicotinic. Muscarinic receptors, there are a number of subtypes from M1 to M4. M4 receptors seem to modulate the tone of dopamine tone by activating receptors in midbrain areas. So if you look at the figure on the left, you could see that stimulating an M4 receptor decreases the excitability of dopamine neurons. And the same thing seems to happen in the nucleus accumbens. M1 receptors are in the frontal cortex, and stimulating those receptors leads to decreased dopaminergic activity in the ventral tegmental area. So if you look at the purple area where an M1 receptor is actually stimulating a GABA neuron, which stimulates an excitatory, it actually inhibits an excitatory pyramidal neuron, which in turn decreases the excitability of a dopamine neuron. So in other words, these muscarinic drugs, particularly xanomeline, doesn't act at dopamine receptors, it just increases the excitability of dopamine. So the findings by Eli Lilly led to an early study in 2008 by Alan Breyer and others in Indianapolis, in which they compared xanomeline to placebo in acute schizophrenia. And if you look in the upper left, you could see that on day 25, there was substantially a greater decrease in psychotic symptoms from the brief psychiatric rating scale from xanomeline from placebo. So that was a positive study, but there were serious problems with the drugs. This was a small study, just 10 patients, but 4 out of the 10 patients were nauseated. I'm sorry, 7 out of the 10 xanomeline patients were nauseated. 6 out of 10 vomited. 7 out of 10 had gastrointestinal distress. So in other words, what we know about muscarinic drugs is they cause nausea, vomiting, and people feel miserable on them. So the drug xanomeline was never developed until the idea emerged in the early 2000s of combining xanomeline with a drug that would block its peripheral effects. So you could still preserve xanomeline's central effects on the brain and decrease its effects on the GI tract. And this led to the combining of xanomeline with trospium, which is an anticholinergic, antimuscarinic drug. This was a study from the published in the New England Journal of Medicine, which found just a substantial improvement. This was a study, a 5-week study, relatively brief, in acute schizophrenia. You could see on the upper left that PANSS total was increased. There was very little change on placebo. And if you look down at panel D at negative symptoms and panel E, the Marder factors, which I developed as a better negative symptom measure from the PANSS, you could see that xanomeline trospium had large effects and very high response rates. This led to phase 3 studies. Sorry, this is the phase 3 study, which came out just last year in Lancet. It's one of 2 phase 3 studies, but both of them were both positive and they found the identical thing. Again, you could see in the upper left, XT decreased PANSS total greater than placebo. And if you look at panel D, at the Marder negative symptom factors, you could see that XT had a substantial effect. Now, what about the side effects? Oh, no, I'm sorry. Let me go back to the point of this slide. What's interesting about this phase 3 trial is the effect size. I'm not sure if all of you are able to look at effect sizes, but if you look at, say, antidepressants for MDD, they usually have an effect size of 0.4. A Cohen's D is the sort of a percent of a standard deviation. When you get to something like 0.7, it's really not seen in psychiatric drugs, but the effect size, the Cohen's D for xanomeline trospium was 0.6, which is really very large, much larger than any of the new drugs that were being studied for schizophrenia during the past couple of decades. So, maybe the study was just better done, but the effect size was good, and it was also good for negative symptoms. And you can see on the Marder negative symptom factors, it was 0.44. But it was at a cost of some side effects. Here, the drug at the time was called CAR-XT. That was because it was developed by a company called Karuna. That company was bought by BMS, by Bristol Myers Squibb, and relabeled Cobenfy, but I prefer to call it XT by its generic name. What you could see is that about 19% of patients experienced nausea, 14% vomiting. And also there was a problem with constipation. Now, muscarinic drugs cause diarrhea rather than constipation, but those patients are on the drug, presumably the trospium was causing the constipation. Now, the word from people who were involved in the trial was that patients were able to tolerate it, and that gradually over time they began to tolerate these side effects, and very few patients were discontinued. If you look below at EPS, it's measured by the Simpson-Angus scale and the Barnes-Akathisia rating scale. It was virtually non-existent. So all of the data in double-blind trials that we have for XT now comes from in placebo-controlled trials comes from acute schizophrenia. Here's what happens when patients were continued on the drug. So if you look at the first several weeks, you'll see this is when patients were on XT or placebo, and you could see that advantage of XT. And then all of the patients were on XT for the rest of the year. And you could see that the patients who were on placebo showed rapid improvement, and the patients who were on who had been on XT continued to improve. So the antipsychotic effects of XT were sustained. You know, unfortunately, we don't have controlled studies of XT during long-term treatment, just these open label studies. And you could see, if you look at the Marder negative factors, you could see that patients on XT continue to improve over the course of a year, which I think is interesting and somewhat compelling. Well, what about the side effects? If you look at this long-term trial, this table looks at the proportion of patients who had greater than one treatment emergent adverse event, which led to a dosage reduction. And here you see a different picture that only 3% for nausea and vomiting had to have their dose reduced. This suggests that XT, that if patients can get through those first weeks, they develop tolerance to the GI effects. And I don't know if many of you who've administered found that that nausea is like a major problem early on, and patients hate this drug, but that if they could tolerate it, they're usually able to continue on the drug. And you can see some of the other side effects, like constipation, remains a problem. I think that as we treat patients with XT, we're going to have to be, good doctors at treating constipation, because that's also going to be, because of the balance between the xanomeline and the trospium, may favor sort of a constipating effect of the drug. This looks at a change in weight. The black line is patients who started out with a BMI greater than 30. And you could see that over the course of the year, these patients lost 4 kilos, which is really quite substantial. So there was just very small weight change in the patients who had a BMI less than 30. But, a potential advantage of xanomeline trospium is that it'll be associated with weight loss rather than weight gain. And this looks at side effects both looking at reported adverse events and scales, the Simpson-Angus scale, which is mostly an EPS scale, the Ames and the Barnes-Akathisia scale. And again, in long-term effects, XT causes virtually no EPS. Changing a patient who has EPS from a dopaminergic antipsychotic to XT, the EPS is likely to disappear. Again, the studies were done just in acute schizophrenia. However, muscarinic drugs are likely to be both pro-cognitive and to improve negative symptoms. This is a mechanism that has been well known and why we treat Alzheimer's with cholinesterase inhibitors. During the course of this acute study, which again isn't the right environment for looking at cognition, they did look at cognition in the entire sample, and they found slight improvement. But when they looked at the group that started out with impaired cognition, and that's panel B, you could see that there was a substantial improvement in cognition on XT. And again, looking at Cohen's D, the effect size, you could see again in the cognitively impaired subgroup, you could see this Cohen's D of 0.54, which is impressive. Again, the ideal setting for looking at negative symptoms is patients who are well and stable, not in patients who are acutely psychotic, because cognition improves as psychotic symptoms improve. So this is not the best study for looking at that. This is another sub-analysis looking at negative symptoms. And what you could see is that if you look at the full sample, there's some improvement in negative symptoms. But if you look at those who had prominent negative symptoms during this acute trial, there did seem to be greater improvement in the patients treated with XT. So what don't we know about XT? We have no idea how it compares to other antipsychotics. We don't have a study comparing XT to risperidone or aripiprazole. We only know it does better than placebo. So, this is a question that many of us have. We don't know whether it's a good substitute for clozapine in patients who are treatment resistant. So it's plausible that patients who don't respond to dopamine blockers or have an inadequate response might respond to this different mechanism. We don't know. Now, I believe that XT is getting into the wrong patients. It's getting into treatment-resistant patients, because in order to get insurers to approve it, people have to show that other drugs aren't working. But the ideal patient for XT may be a very treatment-responsive patient who just, has severe weight gain, EPS, they feel miserable on their drug, which is a high proportion of patients on dopamine blockers, and that those may be the patients where we could have a better idea of the effects. And again, we don't know about its effect on cognition and negative symptoms, and we're just getting some idea about how patients tolerate its GI side effects. I think that most of us have found in prescribing XT that the GI effects are really a substantial problem, particularly during the first weeks of treatment. Um, I think, what I've learned in our clinic, we've had, a handful of patients on XT, uh, is that to be very slow in the titration. Uh, uh, XT should uh, be given to people on an empty stomach, not with food. It should be taken at least 1 hour before a meal or 2 hours after. That decreases the amount of nausea and vomiting. Uh, the studies had patients on the lower dose, which is 50 milligrams xanomeline, 20 milligrams trospium for just a few days. I think we found, and I think others are finding, that they should stay on that lower dose for longer to be sure that they develop tolerance to the GI side effects. The next highest dose is the fixed combination of 100 milligrams of xanomeline with 20 milligrams of trospium. And this is probably an adequate dose for most patients. One can increase the dose by another increment, but most patients won't need it. Do it. And I should mention that XT needs to be taken twice a day. So it's BID dosing, which is another sort of limitation. I suspect I'll get questions about XT during the Q&A, and I'll look forward to those. But this mechanism has been interesting, and there are a number of muscarinic drugs that are in development. Emraclidine is a drug which acts on M4 receptors, but it's not an agonist. It's a positive allosteric modulator, which means that it sort of causes changes in the receptors that makes it more sensitive to acetylcholine. But has the same overall effect. An advantage of this is because it doesn't have M1 effects, it could be administered without a peripheral anticholinergic. So this was a phase 2 study which showed positive effects. Unfortunately, a few months ago, we heard about phase 3 trial, which failed. And we haven't seen the results yet. There are many times where a phase 2 signal doesn't get recorded in phase 3 because the study is too large or there are large placebo effects. I think we'll have to learn more, but my understanding is that AbbVie is going to continue to do another phase 3 study. So hopefully this drug will become available. The next group I'm going to talk to is a group where, again, there was a very positive phase 2 study, which failed in phase 3, but it's a drug that's still in development and I believe will be successful. This is drugs that act on trace amine receptors. Now, trace amine receptors are receptors that are in very low concentrations, as much as 100-fold below the usual amine neurotransmitters. But in 2001, it was found that these receptors, these trace amines have a receptor, particularly TAR1, and that animal studies suggested that TAR1 agonists would have antipsychotic-like effects. And it was found that they reduced the firing in VTA dopamine neurons. And as you can see, these, if you look at the traditional trace amines, you could see that they're similar to the usual monoamine transmitters, neurotransmitters, but they're available at much lower concentrations. Many of us were excited when this study came out in the New England Journal of Medicine. And again, this showed a substantial improvement of this drug, which seemed to be a very effective antipsychotic. If you look at the phase 2 trials on negative symptoms, and the current name is Ulodorant, and it's being developed by Otsuka. You could see that it improved negative symptoms in these scales as well. And something very compelling about the drug is it doesn't cause nausea, it doesn't cause EPS. It, in fact, slows gastric emptying, so it's also associated with weight loss. It doesn't elevate prolactin. It seemed very effective. And this is similar to what I showed you with XT, where the drug initially was compared to placebo, and then all the drugs went on Ulodorant, the TAR1 agonist, and you could see that patients continued to improve. They lost weight, and again, there were just no side effects. The lack of side effects is almost creepy with this drug. As I said, the drug, there's a phase 3 trial where it didn't separate from placebo, probably because of a very large placebo effect. That study is being repeated. It's a large multi-center study. And I'm given the large effect size, I would be surprised if it didn't turn out to be positive, and that we won't be seeing a TAR1 drug relatively soon. So there are other drugs that have come along. Roluperidone is a drug which is an antagonist at 5-HT2A receptors, sigma-2 receptors, and adrenergic receptors. It has no affinity for dopamine or cholinergic or histamine receptors. Now, this drug has been studied in a unique population. That is, people who have minimal positive symptoms, but prominent negative symptoms, with the idea that it would be a compound for patients who are not necessarily who are floridly psychotic, but who have prominent negative symptoms. And this is a study where it was compared to placebo. Again, and this is looking at the Marder negative symptom factors. And you could see that the red line, which is the higher dose of and Minerva is the company developing it, but now it's called Roluperidone. The FDA asked the company to do another study. This study was considered sort of a bit ambiguous because of the effect size and the study population. So there's another study ongoing, but I think this drug is relatively promising for a particular distinct population. And again, although the drug, when you looked at negative symptoms, was limited, when we looked at PSP, which is sort of it's a functional scale. It sort of like the GAF. It measures overall functioning. And what you see is a more prominent improvement in the patients on Roluperidone. So again, I think it's a promising drug. These are a couple of drugs which I heard about at the recent schizophrenia meeting just last month. this is a partial agonist at D2, D3. So it may be more similar to aripiprazole and cariprazine. It does have antioxidant effect, and it was found to be effective for total PANS with relatively little EPS. And it had a positive phase 3 signal. So I think that brilaroxazine will probably be available relatively soon. I think that the FDA is considering an IND for it. N-methyl-amisulpiride is a drug which just showed good effects in phase 2. Now, amisulpiride is a drug which is widely prescribed throughout the world, except in the United States, where its development was slowed down, and because the company wasn't able to patent it, we don't have amisulpiride. It's proven to be a very effective antipsychotic, and meta-analyses it's second only to clozapine in effectiveness. It does have D2 effects, so it does cause weight gain and prolactin elevation, but it's an effective antipsychotic. So N-methyl-amisulpiride is a methylated version, which was developed to be to have greater lipophilicity, so it would be higher brain concentrations. It has similarly binding to amisulpiride, and the phase 2 trial was successful. So I think it's relatively likely that we'll be able to prescribe N-methyl-amisulpiride in the relatively near future. So I've talked about these drugs. Now I'm going to mention treatment-resistant schizophrenia, which has been an interest of mine. During the 1980s, I used to go around to state hospitals in California and do consultations on treatment-refractory patients, treatment-resistant patients. And there was very little to do until clozapine came out. And clozapine has been extraordinarily successful. It doesn't fit in with the topic, but let me define treatment resistant and talk just a moment about clozapine, because the discontinuation of the clozapine REMS is consequential. And I want to talk about it as much as possible, because I think we need to prescribe, more patients should be on clozapine. So the criteria is that a patient is considered treatment resistant for research if they don't show significant improvement in positive symptoms after treatment with 2 non-clozapine antipsychotics. But I think if you go into your clinics and mine, you'll find a lot of patients who we consider treatment responders who actually still have a burden of positive symptoms on their antipsychotic. In my clinic, we have about 40% of the patients on clozapine. Now, we're kind of a tertiary care kind of clinic, but I think the number of people on clozapine is much too low. In the VA and in Medicaid populations, it's about 4.5%. And in other countries, it's more at about 15 to 20%. So, as many of you know, just very recently, the clozapine, about 10 to 23% of patients are treatment resistant from their first episode, and patients may become initially responsive to treatment, but then become partially responsive. So it's great. Sorry. But so, as many of you know, the clozapine REMS was discontinued. We no longer need to document an ANC in REMS before prescribing. For somebody who's getting clozapine after a year, you can prescribe a 90-day supply. The recommendations for monitoring are unchanged. So, after a year or two, the recommendations on the label and from FDA suggest that we should do monthly monitoring. However, if you look at the risk of agranulocytosis after 2 years, it's very, very low and similar to many drugs where we don't require monitoring. And many of us are having conversations with our patients who've been on clozapine for many years about whether to continue monitoring. If the patient chooses not to continue monthly monitoring, we tell them if they have a fever or they're not feeling well or viral symptoms, they should call us immediately. And a European task force recently looked at their recommendations. Now in Europe, the clozapine monitoring recommendations were more liberal than ours. But what they're proposing is monitoring ANC at baseline, weekly for 18 weeks rather than 26 weeks, then monthly for 34 weeks. And after 12 months, if there's no history of leukopenia or neutropenia, to do it every 12 weeks. And then after 24 months, just yearly monitoring. Now, I would say that even if patients show a moderate, a mild neutropenia, that their likelihood of develop mild neutropenias almost never go on to severe, life-threatening, severe neutropenias. So I don't even know if that's required. But this is going against the label, but it's something for clinicians to consider. So the final drug that I'm talking about is evenamide, which is a drug which has a relatively unique mechanism of action. It works on glutamate, and it works on voltage dependent sodium channels. What it does is it modulates, as you can see from the middle panel, when neurons are, glutamatergic neurons are firing at a normal rate, evenamide doesn't have an effect. But when they have high frequency firing, they evenamide attenuates that excitability. And as you can see from the panel on the right, which looks at the higher dose of evenamide, which you could see that it attenuates, it inhibits glutamate release without affecting basal glutamate tone. So it sort of acts on dopamine through a glutamatergic mechanism without blocking dopamine receptors. And this is from a phase 3 trial, which was successful. You could see this. These are patients who were on an antipsychotic or clozapine. So this is a second-generation antipsychotic or clozapine who continue to have positive symptoms. They were randomized to evenamide in addition to their current drug, antipsychotic, or placebo. And you could see that there were advantages to evenamide. Now, although the difference doesn't seem great, one needs to bear in mind that when somebody has treatment-resistant symptoms on clozapine, it puts things to a stop. So a drug that can improve those, can help those patients, I think would be extraordinarily interesting to many of us. Um, Evenamide is now in a large um, phase 3 trial, which is just about to begin, and hopefully these findings will be we'll also find positive findings. So, in summary, this is my final slide. I've tried to emphasize that we're really in a time of a new pharmacotherapy for psychosis, which I consider very promising. We're really at the very beginning of that phase. I think XT is the first drug, but it's a normolentrospium, but I think we're likely to see other drugs with the same mechanism during the next few years. I'm optimistic about other non-dopamine drugs, including TAR1s and TAR1 agonist. Roluperidone looks promising. Brilaroxazine and methyl-amisulpride don't fit into the group of non-dopaminergic drugs, but I think that they'll be new, and I believe that amisulpride will certainly have a place, and brilaroxazine, I think we'll just have to see. And then I'm hopeful that evenamide and possibly other drugs will be available for the large populations of people with schizophrenia who are treatment resistant. It's my final slide. Thanks very much for listening. I'll stop sharing, and I'll be very interested in your questions.
Dr. Marder, that was like an orchestra piece. That was amazing. And for anybody who wants, we'll have the video posted also at the Silver Hill website. That was just remarkable. Thank you so much. We have questions coming in, and I'll go ahead and start with a couple general ones that came right at the top as you started speaking, and then we'll get into some of the more specific ones if that works. So the first question is, are any of the drugs that you discussed also appropriate for schizoaffective disorder? And what do we know about that?
Yeah, it's unfortunate that when these drugs are studied, they're studied in people with schizophrenia and they exclude schizoaffective patients. I hope so. I mean, again, I think this is going to be, I think most of us find that antipsychotics have a major role in schizoaffective disorder. But again, particularly with XT, which is available now, I think it probably will be, but we'll just have to see.
And do you, I mean, this is really remarkable, kind of this new world that we're in with these drugs. Do you foresee kind of in a new onset psychosis starting with one of these agents as opposed to what we've been using traditionally?
So here's my fantasy of the future.
Good,
Uh,
good. I want the
that,
Marder fantasy.
that all of these dopaminergic drugs will be embarrassed that we ever prescribed them, and will go on to these newer drugs. I mean, again, I tried to emphasize in my talk that blocking dopamine receptors comes at a cost of, the ability to fully enjoy and experience life. Now, many patients do extraordinarily well, but I certainly could see a role of these drugs being first, particularly xanomeline-trospium, which is the only one which is currently approved, xanomeline-trospium as being a first-line drug for psychosis. Amisulpride is a first-line drug in many European countries. So I think that could also be a first-line drug for anyone with psychosis, and maybe as a first antipsychotic.
Great, thank you. I like the the vision there. The next question here is, do any of the insurance companies cover the newer antipsychotics? And I guess that would be XT since that's really the one that's out.
Yes, it's a prolonged battle for us. But in my clinic, we have been able to get patients on XT. It's very costly, so it's almost, except for very wealthy people, we don't push it. Uh, the problem is one that I talked about is that it's getting into the wrong people right now. And this happens with a lot of new drugs that the first people to get on the drugs are people who failed on everything, because that's what insurance companies will approve. Uh, and and again, XT may show its greatest effectiveness in people who also respond to risperidone, but they're going to feel better uh, and they're going to enjoy life more on XT, I hope. Uh, and again, we haven't seen that in either clinical trials, but we are getting some reports of patients who sort of like XT. There's uh, a study published by Phil Harvey using EMA, ecological momentary assessment, where patients report back what they have. And people who received XT, and this again was in a company trial, but they experienced more positive emotions.
Hmm.
That, so I hope that that translates it into the clinic. And, and again, the drug has to get into the right patients in order for us to see that.
Remarkable. Question here about the risk of mania with these drugs.
I have no idea. I think their dopamine blocking effects would probably provide some protection, but I have no idea.
Okay.
We'll see.
I think you answered this for us. I'll ask it and make sure I got it right. Does starting XT at a much lower dose and titrating up slowly decrease the incidence of GI symptoms and nausea and vomiting? I think you told us yes, and that we get used to it. Did I get that right?
No, you got it right. And that's, only because I've been both from my own experience and every time I find a psychiatrist who's prescribing XT, I I question them, I interrogate them about what they're finding, and I think that many of them have found that getting patients to tolerate the lowest dose before going on to the higher dose is probably the right thing to do. And and again, I don't see that there's a big rush. Now, one of the questions is, do you cross titrate? Uh, and would there be some benefit? Because, antipsychotics were, uh, phenothiazines were anti-nausea drugs. They still decrease nausea. So if you cross titrate, will that have the effect? And I think maybe, we're sort of, I feel a little bit embarrassed to be sounding like an expert on the drug when I've only had a handful of patients because it's only been available for a few weeks. So it's really hard to know. I think we're going to have a collective experience about how to best prescribe XT. But I think the critical thing now is not taking it with food and staying on the lowest dose for an amount of time, even if it's a week, even if it's more than a week.
So, question here. If someone has had like some response or partial response to clozapine, would you add XT or would you switch? You were kind of getting to
Yeah,
that question.
yeah. We've had experiences, and again, these are unverified reports. One person was able to lower their clozapine dose substantially when XT was added, and they say that they're doing better. And Jeff, there's kind of a story here that the major metabolite of clozapine, desmethylclozapine, actually has muscarinic effects.
Oh,
And
wow.
there is kind of a literature which is a little bit vague, but suggests that patients who have higher ratios of the metabolite to clozapine actually do a little bit better. Uh, I mean, there is a story that clozapine, may have some muscarinic.
Hmm.
Again, it's an anticholinergic, but it has some muscarinic agonism, at least from its metabolite. So I'm hearing stories about some improvement with XT, but they're just clinical vignettes. We'll have to hear more.
Great. Here's a couple questions from I think a very informed participant who says, thank you. Have you heard that they are looking at the data and analyzing that the higher dose of XT has more T, so the side effects actually decrease as you increase the dose because of the higher proportion of T? And what are your thoughts
Right,
on that?
right. T is trospium,
Hmm?
and that's the
Peripheral.
the peripheral anticholinergic, and that's right. And that's what causes constipation. And the constipation, according to the people who've been in clinical trials, they'll tell you that the bigger problem is constipation.
Hmm.
And those of us who prescribe clozapine are have become expert poop doctors. We're very good with constipation because the major more people die from on clozapine, more people die of bowel obstruction than any other cause. So we're very alert to constipation, and I suspect we'll have to do the same with XT. And it's right when you get to the 100, I think it's 150/40 dose, which has more trospium. You'll probably have higher rates of that. It's a very good rate of trospium, and whether or not you can reduce it is, another question.
Hmm. Another question, have you heard of boosting the effect with low dose fluoxetine through the P450 2D6 system?
Of XT, or
I think so, yeah.
no, I haven't. Uh, by using some fluoxetine. Um, no, I haven't heard about that, but it's an interesting idea.
Huh. A couple of uh, tactical questions. Does concomitant Zofran work, and can the pills be split in half?
I, I don't know about splitting the pills in half. Uh, I should know this, but whether they're tablets or capsules, and whether they could be split in half. I think that you could easily find out. I haven't done. Yes, Zolfran. We have tried it. It seems to be somewhat helpful. Uh, I think anything else you could give for nausea might be helpful as well. And again, I think it's what we do is in my clinic is we tell patients to expect nausea. It's part of the effect. Call us. We have strategies for managing it. Whether to start it at the same time, I don't think I would do.
Hmm. A question here, can you go over the mechanism of constipation and what is XT's half-life?
Well, the constipation is the comes from the trospium, and it comes from its anti-muscarinic effects. So I think we know about that. Uh, Trospium. So you look at the half-life of trospium, which I don't know offhand, and you can actually prescribe trospium. My recollection is that it has a relatively short half-life, and I think I could I know this is very minor league, but I'm going to tell you what the half-life of trospium is because
Of
I should know. Uh, Half-life is 20 to 35 hours, so it's got a relatively long half-life.
Great. In the studies of XT, how there's a question here about how cognition was measured.
They use the Cantab battery. It's it's a well accepted. I'm not sure why they selected that one. Probably because it's relatively brief, but it's a well validated cognitive battery. Um, and again, I think in the future, I think we'll have to look at other populations. You know, I think the ideal study would be looking at patients before, you know, on their prior antipsychotic, do a cognitive battery, change them to trospium to the XT, and see if there's improvement. Um, and hopefully those studies will be done. I don't know whether they're going to be done in the near future.
Got it. Got it. With newer antipsychotics, there's a question here, um, and even others in general. How do you advise patients about avoiding substances like cannabis that might trigger or induce psychosis?
Um, that's those are conversations that we have continually with, particularly with, well, now it's not just with younger patients, it's with all patients. And, you know, I think the first thing we do is we recognize that people feel better on cannabis. Many of them who take cannabis, they feel better. We can't take that away. What we have to do is to tell them that it makes their illness worse and it makes it hard to recover and it impairs their functioning. Uh, and that people who have a psychotic illness are they're different than their friends who can tolerate cannabis. I mean, I think they have to accept that there's something different about their ability to tolerate the drug than for other people. Otherwise, we're having a just saying that it's bad for you is bad. The other thing is that there are a number of well done studies that suggest that cannabis users have a worse outcome than non-cannabis users. That cannabis seems to contribute to overall poorer functioning and a poorer antipsychotic effect. And what we do, Jeff, is we talk to patients. What are their goals? And their goals are usually to, to flourish at school or at work and things like that, and to make the case that we have good evidence that cannabis will interfere with that. It's a very difficult conversation, particularly in California, where you can walk down the street. I mean, around the block from me, there are several cannabis dispensaries.
Yeah, yeah, that's a great um, words of wisdom, though, in terms of that clinical communication. Thank you. Thanks so much for that. So do you know, are there programs either with the drug company or that you know in terms of making XT available for patients in some kind of more or less cost prohibitive way, or is it really kind of for those who can afford it?
Uh, you know, you could get these starter packs, uh, and I think the company distributes those. But I think that I don't know. I think that would be uh, people should ask their BMS rep about that, whether or not there are programs for getting XT, and whether or not they could help in getting it approved by insurers. And I don't know whether uh, Medicare and Medicaid will be approving XT relatively soon. I think that will open it up to a very large population of people with schizophrenia. uh, at the VA where I am right now and where I spend part of my time, uh, they will only approve it after, for treatment resistant patients.
Right.
And as I said, those are the wrong people. The other thing I would say if in trying to get an authorization from an insurance company is to emphasize that the adverse effects of at least two antipsychotics are difficult for the patient to tolerate, uh, and not to emphasize the fact that it's not effective. And maybe they'll find a winner there, but it's
Mhm.
uh, yeah, getting access to the drug is going to be a problem.
Gotcha, gotcha. The questions keep rolling in, Dr. Marder. Are there, or what is the effects of evenamide on negative symptoms?
Um, it's only been given in treatment resistant patients. Uh, the On PANSS negative, it did show some improvement in these trials. But again, when you give a drug, when you decrease psychosis, negative symptoms secondary negative symptoms seem to improve. That is, that patients are, they're less preoccupied with hallucinations, they're less suspicious, they're more outgoing. So when a drug in this population shows improvement in negative symptoms, it's good, but one needs to be a little bit wary of those kinds of findings. Um, but I'm not sure that evenamide will be a drug for negative symptoms in responsive patients. We'll see.
Great. Uh, uh, great, great. I'm um, seeing a question here that says, I am so impressed by the TAR1 agonist, uh, Ulotaront. Is that
Yeah, you Lodorant, right?
yeah, Laura. Can you explain why it failed phase 3 clinical trials? Because it sounds like a wonder drug. Uh,
Yes, I can. I could give my explanation. So, uh, a number of things happened, and this uh, one they when drugs go in phase two trials, that usually happens in relatively expert centers. When a drug goes into phase three, it goes usually into like hundreds of sites and internationally. And signals sometimes go away and placebo effects get larger. Patients aren't carefully selected. So that was one thing that happened. There was a large placebo effect. So the amount of improvement on your Ulotaront was about the same as it was in the phase two trial, but the placebo effect was much larger, so it didn't separate. The other thing that's interesting is the study started pre-COVID, and pre-COVID there was a signal, and then everything fell apart, and I think sites became less expert. They lost staff, and then post-COVID, the signal was lost. And I think that's probably because the centers kind of deteriorated in quality. So there are a number of reasons, but these very large trials sometimes do. I think that what happened is the xanomeline trospium trials and the Ulotaront trials occurred at about the same time. And I think that there are lessons from the way that the Karuna, then the company, did those trials, that they were much more, they were more careful. They did it at a very few sites, all in the United States, and they got a good result in phase three. Whereas Synovian, which then was doing those trials, went to these very large international studies, and they got a large placebo effect. That's probably more than the questioner wanted to know, but
Thank you.
it's just a particular interest of mine.
Yeah, thank you. Also, a reminder to everyone to put questions in the Q&A and not um, uh, raise hand because we can't get to those as easily. Question: what would be the benefit of the methyl amisulfuride over other second generation antipsychotics other than clozapine?
You know, I think it probably will have advantage in negative symptoms. Uh, Initially, when it studied, there was a study in as an antipsychotic with patients with prominent negative symptoms, and it did particularly well. Uh, I think it is in meta-analyses, it actually has been shown to be more effective than all of the second generation drugs, slightly more effective. And it's second only to clozapine. So it might be an alternative drug for people who don't do well on other drugs. It's pretty well tolerated. It does have weight gain and prolactin elevation, but I could see it becoming a first line drug, um, uh, and maybe an alternative to what are currently first line drugs.
We have a comment here that says, "Thank you for allowing us to pick your brain, Dr. Marder." And the questions keep rolling in. I'll keep going for it. For the next, we have about 5 or 6 minutes left. Back to the GI side effects of XT. Question about ondansetron and miralaxin, if those are helpful, and is that part of the armamentarium that you use in your clinic?
Well, we have tried ondansetron, as I said, and it does seem to be somewhat helpful. And for the constipation, yeah, I think we'll probably it's maybe different than Miralax would be a very good choice for clozapine constipation. For clozapine constipation, you don't use like Metamucil bulk laxatives because they can actually make the problem worse. So Miralax would be a good alternative. I think we're just getting experience, but I think probably the normal, drugs like Miralax and other drugs for constipation. I don't see that be very special. We're just beginning to learn. That's a wishy-washy answer
No, that's good.
because I haven't really had personal experience with that.
Uh-huh. There are questions here about comorbidities and things to think about in terms of comorbid issues that our patients might have when prescribing XT, like comorbid substance use or other comorbid psychiatric issues that would be something to think about.
Well, I mean, if you look at the mechanism, if someone has a large anticholinergic burden from other medications, XT may not be effective. So, I mean, if you're changing if you're doing a cross titration and someone's getting benztropine, I mean, it might mute the effectiveness of XT. I can't think of any comorbidities right offhand that would be a problem. Uh, I mean, I can't think of cardiac attacks. I don't think it prolongs QT, but don't quote me on that. No, um, I
Not
can't think.
not right offhand. Yeah.
Not right offhand. I can't think of any.
Okay. I'm combining questions now here in the name of time. Thoughts about the use of XT in the elderly, and also is there information about uh, um, the use of these medications with those who have the C4 gene, increasing their risk for schizophrenia genetically?
Well, let me go for the first one. XT is now being studied in Alzheimer's and Alzheimer's psychosis. So I think we'll learn more about it but and originally it's pro-cognitive. So, it might very well have a role uh, in that population. So the C4 gene is really, it involves neuroplasticity, and whether or not uh, this would have effects there, I think is unknown. Um, I, one would have to. I'm not aware of any particular effects, and I'm not aware that it would be studied. I'm trying to think about the mechanism of action, uh, uh, and, and the fact that it doesn't, glutamate doesn't seem to be a factor in NMDA receptors. So I really can't comment. I really don't know.
Mhm. And if an individual is already taking clozapine, this may be a variant of what we had talked about. Would taking XT or evenamide serve as an agonist for the effectiveness of clozapine?
Uh, Unknown. Again, people are starting to experiment, and and again, there are some people who've had experiences that adding it to clozapine, they got positive results, and a couple of people where they're able to reduce their dose of clozapine. But I think one can come up with a plausible reason for combining it with clozapine. But again, one would really need clinical trials, and one would have to wonder whether or not the anticholinergic effects of clozapine would, how that would affect its
Right.
effects. So I think it's very unclear.
And do you think any of these will eventually be available in long-acting injectables?
It's hard to, the drugs that are available in long-acting injectables tend to be drugs which are highly potent, so that you could get it into a relatively small volume to inject. So a drug like xanomeline, which is effective at 100 or 150 milligrams, it doesn't sound promising. So I really don't know, but it doesn't sound promising to me at this stage. I mean, whether or not there's another way, a transdermal mechanism, or some way to avoid nausea, I have no idea. But then, even if it was a transdermal, it would have to be very, very large. So I don't know. I haven't heard about that.
Great.
But
I think we're at the 30th question here, Steve. So wow, a lot of interest, and they keep rolling in. But here's one for you. Is there a risk of agitation with higher doses of XT, as has been true for aripiprazole?
um, I don't think so. With aripiprazole, I think it's the it's the dopaminergic effect, and just mechanistically, I can't think that the drug would cause agitation, except, when patients feel nauseated, but that's different. I don't think it would cause agitation. It's a good question, though.
All right. Well, Steve, it has just been an honor to spend time with you, and I've learned so much over the last hour and a half. So thank you. Thank
Thanks,
you um,
Jeff.
very, very much for this inspiring presentation. Thanks to everybody out there for joining us, for the many questions, and so actively participating. As a reminder, for those wishing to receive continuing education credits, please complete the evaluation survey that will automatically show in the browser as we end the webinar, and you'll also get a copy of the slides. And there was a question about that as well. We hope everybody can join us again on May 7th. But for now, Dr. Marder, thanks again. And this concludes our grand rounds for the day. Thank you.